Welcome back to this video about how to anesthetize haemoabdomen. So this case is Delit a 12 years old shepherd cross female that is coming to see you because she had a sudden collapse. You'll find out later that she's got haemoabdomen because of splenic mass, and then she would need to be anesthetized for splenectomy. But on the clinical exam, her mucous membrane are pale and moist. Her CRT is between 2 to 3 seconds. Her heart rate and pulse rate are very elevated with a heart rate of 160 beats per minute. She's got a pulse that is asynchronous and hyperdynamic, and there might be some evidence of pulse deficit. She's got a heart murmur, apex systolic grade 2 out of 6, and she might have some arrhythmia on the auscultation. The respiratory system examination revealed a tachypneic patient with a normal chest auscultation. The rectal temperature is normal, but her behavior is very abnormal because she's collapsed, and she scored on the modified Glasgow pain scale 2 out of 24, which doesn't require at this time any analgesia intervention. So all the question I'm sure you're asking yourself is, should I anesthetize it now? If I don't, do I have time to do some extra tests? What tests do I need to do? And how do I restate her if I need to? And what are the anesthetic risks? So what to do? Before you anesthetize her, you need to assess the situation. So doing a clinical exam, specifically heart rate, respiratory rate, and pulse palpation to have an idea of what's the quality of the pulse, temperature, and auscultation of the chest. You want to do bloods, so specifically hematocrit and total solid, to have an estimation of the blood loss potentially. Venous blood gas is ideal because you can have electrolytes as quickly as possible with maybe the lactate and some evidence on the evidence of acidemia or alkalemia on this patient. Biochemistry and hematology would be also a good addition because this patient is also old. In terms of monitoring, having the systolic blood pressure checked or the mean arterial pressure is also quite beneficial. And an ECG would be good as well because you have evidence of arrhythmia on the auscultation. And after you assess, you want to stabilize. Yes, there is evidence of bleeding, but often with those patients, it's not an active bleeding. So you have a bit of time to stabilize them because the more stabilized the patient is, the less likely they are to die, obviously, under the GA. So how do I restate it? So I just want to point it out to you. There is 2 other videos on haemoabdomen done by Chris Monda and Lee Minkin, where they discuss the medical and surgical approach to haemoabdomen. But today we are going to speak a bit more on the stabilization for an anesthesia point of view. So first, you want to know how bad it is. So there is a little classification that was produced from the American College of Surgeons that help you, according to your clinical exam, to have an idea of the severity of the blood loss and some action that might need it. So if we take back her clinical exam, so her mucous membrane are pale and moist, her CRT is prolonged, she's tachycardic and tachypneic, and she's very collapsed. So that's probably placed her in between class 2 or class 3, so mild to moderate bleeds, which means that she might or might not need some blood transfusion at one point. So which means that she's quite severely affected by this hemorrhage. So what's the end point of the resuscitation? So the end point of the treatment strategy is to focus on restoring tissue oxygenation. So for instance, in this patient, after further examination, so you can see the heart rate is higher than 120. She's mucous membrane are pale and tachy. CRT is prolonged. She's depressed. You've done some blood gas and then you found the lactate are elevated, so more than 3. The pH is lower than 7.25, which means that she's got moderate acidemia. Her systolic blood pressure is less than 90, so which means that she's hypotensive and she's got a higher shock index. So that's on arrival. So what you want to target before the GA is an improvement of all those parameters. So the resuscitation should aim to be better, especially in terms of heart rate, having a CRT less than 1.5. The mentation often should be improved. Lactate should be decreased. and the systolic blood pressure should be increased. So how do you do this? Well, you give fluid boluses. So typically using a balanced electrolyte solution such as Hartmann is a good start. You can start with 10 to 20 mils per kilo over 10 to 20 minutes and then continue at needed until there is no response. But what you want to aim is for the heart rate to be less than 120 to start with. So coming back to this algorithm on tailoring anesthesia plan. So what are the anesthetic risks on this patient? So we're going to see first patient, procedure and pathology. So first the patient, so this is a geriatric patient, which means she's got a decrease in cardiorespiratory reserve. She's got a decrease in cognition function, so she might be a bit more stressed and have an increase in catecholamine release that could further increase the risk of arrhythmia, for instance. She might have subclinical chronic disease, hence doing extra tests to make sure we accounted for them when we decide the plan of GA. And because she's a large breed and she's geriatric, she probably have some osteoarthritis already installed. So you want to put 2 IV catheter to be able to provide appropriate resuscitation, but also to have effect to be able to provide analgesia. The choice of drug should be taking in account the cardiorespiratory effect of those. So you want to target low cardiorespiratory depression effect. Obviously analgesic drugs, as we said before. And because they have a decrease in respiratory reserve, you might want to consider to pre-oxygenate them. Because she's got a haemoabdomen, she's at high risk of hypertension, and she was already hypertensive before you start the GA, which means that the cardiac output would be massively decreased. She's also high risk of hyperventilation because of the volume on the abdomen pushing against the diaphragm. She might display pain or nociception during the surgery because it's distending the abdomen because of the volume. Also, at the moment, she's not displaying any need for analgesia rescue. So when you consider this patient with haemoabdomen, you have to think about 3 points: how you're going to manipulate them, the drug choices, and the monitoring you're going to use. So typically, manipulation, you want to do gradual position change. So for instance, changing from sternal to dorsal is probably not advised for a few reasons. First, if they are being in dorsal straight after they've been in sternal, the dependent part of the lungs are suddenly the non-dependent one, which means that there is a risk of massive atelectasia in the whole lung field, which would reduce the capacity of ventilation. Second, moving them too fast could also affect the cardiovascular system and trigger sudden hypertension. You want also to be careful with the abdominal palpation, especially on the examination or when you clip the patient, because you don't want to further increase the bleeds, but also you want to make sure the patient stays comfortable. And you also have to be careful when you lift those patients. So using a sling, for instance, that take the whole patient into a big blanket, for instance, to lift them is quite useful for your back, first of all, but also to avoid any further compression of the abdomen or maybe bad manipulation of the hip because she's older. So the hypertension could be triggered by the original bleed, but also further bleed during the procedure. So because there is a high risk of hemorrhage when you remove the spleen. There is also a risk of coagulopathy because of a massively decreased hematocrit, but also because of the resuscitation where you can have a diluting coagulopathy. There is also a high risk of arrhythmia in this patient, especially ventricular premature complex, hence having a good monitoring with an ECG. So when you think about the drug choice because of this, you want to use cardiovascular friendly drugs, so typically avoiding drugs such as ACP or dexmedetomidine. You want to use drugs that might be antiarrhythmic, potentially maybe in this situation avoid ketamine because there is a high risk of arrhythmia, and maybe favor lidocaine. You want to use drugs that have max brain effects. You want in no circumstances on those patients you use non-steroidal. First, because there is a higher risk of bleeding giving non-steroidal, but also because they are at risk of hypertension and therefore decreased kidney function. You want to favor fluid therapy, hence we said earlier giving 2 catheters, and you want to consider vasopressors, so you need to check what you have available and what you're comfortable to use with and which one you might use and how you're going to provide it. So the hyperventilation could lead to hypoxemia and hypercapnia. So again, in the drug choice, you want to consider pre-oxygenate the patient with a mask before you do the pre-medication. You might have to give controlled mechanical ventilation or IPPV because the patient is going to be on its back and then the fluids would compress the diaphragm. So, and because she's also old, she's less likely to ventilate appropriately. You want to use obviously drugs that are respiratory friendly with less respiratory depression if you don't have any way to ventilate the patient. And then drugs also with maximum effects to reduce the effect of respiratory depression of other drugs you're using. Again, she's at risk of pain because abdominal distension. So you want to provide drugs with analgesia and multimodal effect. So just a little reminder, when you treat pain, you want to think about treating the actual pain and preempt and prevent the pain that the patient might sustain during the procedure and after the procedure. So in terms of monitoring, because of all this risk that you're preempting, you want an ECG and an SpO2 and tidal CO2 and monitoring of the arterial blood pressure. Ideally, an oscillometric system, even better invasive blood pressure monitoring. But if you don't have that, that's fine. You can use an oscillometric or Doppler. So regarding the consideration of the procedure, so because it's an exploratory laparotomy, it's an emergency surgery. The patient have high risk of hyperventilation because the patient is going to be on its back. There is a high risk of hypertension for many reasons, as we discussed before. And there is also a risk of bleeding and hemorrhage because we're going to remove the spleen. There is a risk of pain, obviously, and risk of hypothermia because obviously you're going into a very big cavity that normally shouldn't be in the air, but also you have a very large clip needed to the surgery safely. So again, if you consider manipulation, drugs of choice, the choice of drugs and the monitoring. So first, because it's an emergency, you don't know if the patient has been starved. So therefore, if he hasn't been starved or if he hasn't eaten for a very long time, there is a high risk of regurgitation. She also might be dehydrated if she hasn't eaten for a while because she was sick. She's also very stressed. So in terms of manipulation, you want to do a head-up induction, meaning that you want a quick endotracheal intubation with the inflation of the cuff while the head is still up to avoid any aspiration. And same at the recovery, you want to do a late extubation with the cuff partially deflated in case the patient has regurged during the procedure. That would help to pull out any regurg that sat on the cuff during the extubation. So consideration now, if we order them on the ladder of importance, hemorrhage is a big concern, hypoxemia and hypercapnia as well, followed by arrhythmia, pain, the age of the patient, and the risk of hypothermia. So how do we do? So first, the pre-medication should provide sufficient analgesia, so with methadone. You can consider giving also lidocaine at 2 mg per kilo over 2 minutes. That would provide a very good analgesia as well, and can provide also a bit of sedation. At this dose, you shouldn't really see any you shouldn't see any nausea sign, but you never know. But as we said before, you want to maintain the head up. You can consider also giving paracetamol at 15 mg per kilo IV before you anesthetize them for further analgesia. And then you want to pre-oxygenate the patient for 5 minutes with a mask, keeping the head up before the induction and to provide a tracheal intubation with the head up. And as we discussed, cuff with the head still elevated. To induce, you can give an IV co-induction with propofol at 1 mg per kilo and followed by midazolam at 0.4 mg per kilo. You want to do that in this order to avoid any excitement. And if you need further, you can top up with propofol to effect. Usually when the patient is very sick and old, just 1 mg per kilo of propofol and 0.5 mg per kilo of midazolam is enough. And then to maintain the GA, sevoflurane, isoflurane, there is no specific consideration there. You can use either way. Like giving a lidocaine CRI is quite beneficial, between 30 to 50 microgram per kilo per minute, because it would provide max-brain effect, some analgesia effect as well. There is also some antiarrhythmic, especially for ventricular premature tachycardia or premature complex of tachycardia on those patients is very beneficial. And there might be some evidence that the outcome is improved when the patient has received lidocaine CRI. And then obviously continue fluids with Hartmann at 5 ml per kilo per hour. So in terms of monitoring, a must would be heart rate, respiratory rate, and temperature. SpO2 would be very, very advised, as well as monitoring the mean arterial pressure or the Doppler. And then ECG would be even better. So before you anesthetize them, you have to think about what can happen, as I said earlier. So often they can be painful. So what to do if they are painful? Then you can give further methadone between 0.1 to 0.3 mg per kilo in total. So give 0.1 mg per kilo boluses at the time. You don't want to increase the methadone more than 0.5 mg per kilo in total. So for instance, if you have started with 0.3 mg per kilo of methadone, you can top up to 2 boluses of 0.1 mg per kilo during the procedure. If you think it's a short-lived painful stimulation, you can give boluses of phentermine instead, 2.5 to 5 microgram per kilo. Be reminded that phentermine can produce a very profound bradycardia. They can stop breathing, specifically after you gave methadone or fentanyl. In that case, you can try to reduce inhalant to see if you can have a lighter plan of anesthesia. You might have to hand ventilate if you don't have a ventilator. Be reminded that ventilating would also affect the cardiac outputs negatively. They can become hypertensive. Very likely they would become hypertensive. So they would be evidently hypertensive because the mean arterial pressure would be less than 60 or the Doppler would be less than 90. So again, you can start by reduce inhalant because they affect the blood pressure by vasodilation and decreased contractility. But if it's not enough and the patient is very tachycardic, that might mean that it's obviously hypovolemic, or if you have any evidence of massive bleed when you do the surgery. So you can start by giving fluid boluses, 10 ml per kilo over 10 minutes. And if responsive, you can repeat it until not responsive anymore. At this stage, if the bleed is massive, then you might have to consider giving a blood transfusion. If the patient is not fluid responsive anymore, that might be that he's hypertensive because he's very vasodilated. So considering a vasopressor such as noradrenaline is a good idea. So you can start 0.1 microgram per kilo per minute up to 1 microgram per kilo per minute. Do not bolus noradrenaline because that can lead to the development of ventricular premature complex / ventricular tachycardia. And when you do your dilution, make sure that it allowed a fast volume per minute at the lowest concentration or dose that you want to give. The patient could have bad recovery, especially when they are a bit older, and this Bleeding Shepherd typically could also have bad recovery. So that could be because they're painful or disorientated. So if they're painful, give more analgesia such as methadone or fentanyl. But if they are disorientated, then you can consider giving propofol 1 to 2 mg per kilo until they just calm down. So that's it for this case. Thank you very much for listening, and I'll see you next in the third video about White the cat and the haemoabdomen.